best to differentiate from a regular vestibular specialist to the audio-vestibular specialists. So that being said, let's make us feel a little dizzy. Okay, so if this makes you feel dizzy, that's good. I'm trying to do my job to gain your attention, and we had a good introduction on myself, so I'm not going to pay any attention on my interview. Okay, so let's focus on at least 5 different aspects on what I'm going to discuss with you guys. I'll probably share information with you. So the first one is, let's have a closer look at the vestibular and balance disorders. So before going into the balance and vestibular disorders, first let's learn basics of vestibular and balanced system. Again, I'm not going to pay too much attention on the anatomy or physiology or even on any test. It's just a gross idea to keep everything in one particular session, probably within next 70 minutes. So I think we all are comfortable with the basic anatomy and physiology, right? We have 3 different semicircular canals, superior, posterior canal, and then lateral, and we have maculae, which is the otolith organs, utricle, and then saccule. So what do we do? So what kind of information does this system carry to the brain? So we have semicircular canals. As we can see, this tiny cow is actually dancing. So when we dance, not just the cow, right? Even when I dance, or you dance, the majority of the motions are angular motions. Like you're rotating, you humming, you run, jog, anything is angular motion. So that is being detected by the semicircular canals. Then the second one is otolith organs, maculae, utricle and saccule, detects linear motions. Again, there are 2 different types of linear motions. As now you can see, the cow is actually moving just forward, right? Forward and backward being detected by utricle. So that is the forward and backward linear motion. And there is another set which is the detected by saccule, like vertical linear motion. Now you can see the tiny monster is dancing. That is the angular motion. And then the linear motion is just jumping up and down, or probably going in an elevator or lift up and down. So that is the linear motion. So these are the 5 different sensors located in our balance system. So we have fancy phones, right? Expensive phones to cheap phones. Nowadays, every mobile phone comes with at least 3 different sensors. That is gyroscope, accelerometer, and gravity sensor. But what we don't know, what we don't realize is that our vestibular system is even more capable, and it's even more complex and advanced. We have it in our body, fortunately, 2 working vestibular systems, and we are fortunate to have them, but very unfortunate if anyone have an abnormal functioning vestibular system, because you know how terrible it might be. So now we know we have 5 different sensors in each ear, and that has to carry information to the vestibular system, or probably to the brain, right? So the information is carried by 2 different branches of the nerve. So the first one is superior vestibular branch, and obviously is carrying from the anterior canal and lateral canal and utricle. And we have inferior branch that is carrying the information from posterior canal as well as saccule. So the next question that I have for you, or probably you can answer yourself, which portion is the brain for the vestibular system? We know for auditory system, it's auditory cortex in the brain. But is it the brain, the actual processing unit for vestibular system? Most of you probably might know that no, it is not. The actual brain, the cortex, plays a very tiny role in vestibular system, and we are still studying on those things. We still don't understand what exact contribution from the thalamus or ventricular vestibular cortex. But the actual processing unit is the vestibular nuclei located in the midbrain. So this is the amazing, it's smaller compared to the other parts, but this has an amazing function, not only receiving information from 2 different vestibular systems, also receives information from other sensory and motor. That's what makes this vestibular system complicated as well as interesting. So let's learn about that. I'm not going to pay too much attention, but this is the processing unit. So you want to make it simple, right? I know I attended vestibular classes at the beginning, and most of you might have attended. It scares us. It scared me definitely, but I always learn in a way that I should remember it. So to keep that in mind, keeping that in mind, I'm going to use this particular song from RRR to explain how our balance system works, so that everyone can take some information to your mind and then to home. So let's first understand what are the connections that vestibular system, especially the vestibular nuclei, has that makes it interesting, that makes it complex, and that makes us be balanced rather than having any other issues. The first system is actually the vestibular system combines with the oculomotor system, and that is called as vestibular ocular reflex or vestibular ocular system. If at all, if it actually, the vestibular system talks to the cervical system, basically your neck, muscles, and sensors, that is referred as vestibulocaudalic reflex system. And if the vestibular system actually talks to spinal system, then that is vestibulospinal reflex or vestibulospinal system. And we have more, and the next one is vestibular system with the cerebellum. Cerebellum is one of the important part of the brain that actually maintains the balance and helps us in actually maintaining the visual focus, right? So that also plays a critical role, and that is vestibulocerebellar system. And we have one more. So vestibular system, if it talks to the actual corticothalamus, so that is vestibulocortical. Again, as we know, we still know very less about it, and we're still working on it. And it does have little contribution as far as we know as of now. And again, vestibular system is really complicated. The entire system, the balance system. It's just not just these 5 different systems, but we have proprioceptive, an amazing system. You know, our body has complete sensors, either be your nose, either be your cheek, either be your finger. Everywhere you have sensors across your body that also contributes in balance. If you're floating, if you're on cold water, if you're on like a wet surface or on a hard surface, your body know which surface you are on, so that it can actually make you feel balanced. So proprioceptive is amazing. And in recent generation, we see a lot of vascular issues. So earlier, it's not that actually significant. Now we see a lot of issues and the contribution from vascular system and obviously the other systems. So even a tiny bit of health concerns, even stress, there are so many things that can actually affect the vestibular function. So these are the common systems that we have. So now let's revise. What do I mean vestibulo-ocular reflex? So you see this step, and let me know which system that you think that these 2 amazing balances are actually utilizing. Okay, so they're shaking their head and probably looking up at the sky. So which system do you think they're actually utilizing? At least I know that they're definitely using vestibular system because they are shaking their head. When they shake their head, they have their vestibular system activated, and because they're focusing on the sky or probably looking up, their oculomotor system is now active. Eyes. So eyes are working with the vestibular system. This is the ocular system. So obviously the central system has to integrate both, right? So vestibular nuclei. So this system is vestibulo-ocular reflex or vestibulo-ocular system. Okay, so let's look at a basic idea. So on this side, you have a normal functioning vestibular system. So focus on this portion right here on the bottom left. You're going to see the smooth movement of eye. So if a person have normal vestibular system, which we all are, I assume. So if I shake my head, focus on that. Do you see how smoothly it rotates in all different angles? That is the vestibulo-ocular reflex. The head is being controlled by the head information. The head movement information is being sent to the oculomotor system, and it actually moves opposite your head. So that is the normal function. But if at all, for some reason, many reasons, if a person have vestibular issue, now focus on the left bottom corner, you see it juggles. It's not as smooth as a normal person. So that is the nystagmus. Again, I'm not going to talk about what is nystagmus, what are the different types of nystagmus. We might meet another time to actually go over all those things. But let's pay attention. What happens if the vestibular system, probably let's say, is abnormal, or it has been affected, it has been destroyed for many reasons? What are the symptoms that we usually see? The first one could be vertigo, right? And if this vertigo is not untreated or mistreated, that can eventually turn into dizziness. And my God, it can be even worse if the treatment is prolonged or probably inappropriate treatment has been implemented. So we're going to see those things in next few more sessions. But what are the disorders that you might expect in the VOR system? So it can be vestibular neuritis, one of the most common one, and vestibular schwannomas or hypofunction, labyrinthitis, and so many other reasons, right? So that could result in abnormal vestibular ocular function. So let's pay attention to the same step. Now tell me, which is the passive system that is working along with the head? So we know they're moving the same step, but don't pay attention to the ocular system. Which other system that's contributing there? We know the vestibular system is moving. The second system is cervical system. So right now, not only that they are moving the head, if you can pay attention, the neck is also moving along with their head, right? What happens if vestibular system is weaker? So our brain is amazing. It doesn't rely on one particular organ or sensor if it is too important. So you have muscles, the neck muscles, that have sensors and send information to the brain. So whenever you shake your head, not only that your vestibular system or ocular system that's actually detecting the motion, now the cervical system also carries information to the vestibular system saying that, what, I'm actually moving. So all this information is being processed at the vestibular nuclear level, and this is the vestibular cervical reflex. It looks same, but depending on where you focus, it can be vestibular ocular, it can be vestibular cervical. So what are the common signs that you see if a patient have cervical issues, such as neck issues or combination of cervical and vestibular issues? Usually it's dizziness. Not many people complain about vertigo, and then it could be imbalance or it could be lightheadedness as well. But what are the common disorders that can actually induce these? It could be spondylosis, spondylitis, neck muscle spasms, and neck pains. So this is very common in young generation, especially with IT sector, and nowadays even audiologists. We sit too much time in front of computers, right? So that can actually induce the neck spasms and neck pains, and eventually can turn into the spondylosis and other other issues as well. So this is another major leading vestibular issue. Okay, so we did discuss about the neck spasms and the effects of abnormal vestibulocholic reflexes, right? So let's pay attention to this particular step once again. So now look at the step. They're jumping, and they're also utilizing vestibular system, right? So the vestibular system is the utricle and saccule. As they're jumping up and down vertically, it's not the angular motion, it's not the semicircular canals that is actually detecting the vestibular system, but by the utricular system and saccule system. The second one is their feet, right? So the spinal system is being activated now. They're jumping and landing on one particular feet compared to other one, and while they're actually bending or folding their leg. So the spinal system has to work with vestibular system. Obviously, you need the vestibular nuclei to synchronize everything. So that is the vestibular spinal reflexes. It's an amazing response. You don't realize how important the vestibulospinal reflex until you lose that information, but it is really important. So what are the signs that you may see if a person have the vestibulospinal issues? The basic complaint could be imbalance. Some may actually feel like they're swaying or even about to fall. The few people actually do fall, and that could be very risky. And other common signs might be lightheadedness. And what are the common vestibular disorders, or not vestibular disorders, but spinal disorders that can actually result in these issues? Are that it's a lumbar issues, or probably lower back pain, or vertebrate issues, arthritis, and any compression of the nerves or vascular system in the spinal system could actually result in the vestibulospinal reflex issues. So that can result either in imbalance or lightheadedness or swings. So this is a very important system after the VOR actually. So let's pay attention to this one and see what are the systems that actually contributes for this particular motion. It looks definitely complicated, right? So you can see all the body parts are actually moving. Head is moving, the neck is moving, eyes are actually being focused at certain points, and then the spinal reflexes are very, very active compared to what we've seen in the previous step, right? So let me play it once again. So again, pay attention. Body is moving very fast, and they're going to jump at certain point, and they're going to land again properly. So what systems are we actually looking at? It's a very complex function, meaning that more than two systems have to actually work together. Obviously, the vestibular system is key. It is not only detecting the angular motion, but as these dancers jump, it also has to assess how far they're jumping and how fast that they're jumping. And it has to work with the spinal reflexes, because when they land, the system has to know which feet to actually take more pressure compared to the other one. So that is the spinal reflexes, and obviously the neck is also moving. So the colic reflex also play a critical role. And the other systems that we don't talk here but plays a critical role is the proprioceptive as well, because that is the sensor that detects how hard the surface is. If a person, these dancers actually are walking on the same, let's say, steps, but on a grass or on a soft foam, then the proprioceptive actually plays a critical role. If proprioceptive system is affected, then you may fall, even if all these systems are actually working fine. So that is the importance of the overall balanced system. So it's not just vestibular, right? As we see now, we have colic reflexes, spinal reflexes, and the proprioceptive and other systems. So if all these comes together, we feel stable, we feel balanced. If not, even if one of these goes out, you feel issues, but that might change. The other system that we have is cerebellar system. So again, as I say, cerebellar is a key. It actually helps in and hand coordination, and also the head movements, and mainly it maintains the posture stability. If at all, if someone have ataxia, cerebellar ataxia, so on, so then you're going to see some postural instability in the beginning. So what are the signs? Obviously, the imbalance as well as postural instability. In common disorders that we see with cerebellar issues are ataxia, atrophy, hypoplasia, strokes, and more. So these things can also actually cause the imbalance issues. So the very little studied or very little known information is on the cortical system. We really don't completely understand what exact role is, but however, so far what we know is it helps in cognitive perception and also helps in motion and spatial orientation. But again, there are other systems that can do these things, but the research is still going on to understand the exact contribution of the cortical system. So what are the common symptoms? People do actually complain about vertigo if they have issues at cortical level, but it's not as consistent as in the peripheral issues. And people do complain about dizziness as well as imbalance. What are the common disorders? Again, these are in research, and I cannot really guarantee that this is an published data. But so far, what we observe is if a patient has vestibular migraines, that could be an effect on the cortical region. and abnormal brain tissue, such as like ischemic changes, strokes, and even triple PD could be from the cortical, because that actually plays an attention in attention and cognitive function. So triple PD could be from the cortical systems as well. Okay, so I'm going to say there are other systems: vascular system, proprioceptive, and general health. Even we know if you're actually fasting on a festive season, by end of the day you feel dizzy or lightheadedness. So all these things actually do result in vestibular system, and orthopedics, ortho issues also result in the vestibular issues. But now, as we understood, there's more to vestibular system, and if at all, if any of these systems actually goes wrong, the issue is that a human might actually fall, or probably they don't feel confident to even stand or do any other stuff. That brings us to the biggest concern, because if vestibular ocular reflex is gone, or probably the spinal reflexes is gone, or probably the colic reflexes or any other system, if it is affected, including the vestibular nuclei synchronization, if that happens, then you are looking at a bigger problem. So I'm not sure how many of you are aware that we commonly categorize the vestibular issues as peripheral or central, right? But there's more, and if we can, as an audiologist, as a vestibular specialist, if you can find out the precise reason, even if it is in peripheral or central, then you are going to help the client and the physician to actually go with appropriate treatment strategy. So before I am going to talk about anything, let me utilize three different case scenarios to highlight where we stand as an audiologist right now, as even as a physician or any healthcare provider, when it comes to the vestibular system, and where we should actually reach, and what are the things that we are missing, and who and how people are actually suffering. The first one is actually, I'm going to focus on this first patient. It's a very interesting patient. So she's 29 years old. She initially started feeling dizzy and then gradually changed it to imbalance. You definitely feel a lot of imbalance, and it slowly or eventually got even worse, and she feels scared to even stand, and probably even in dark. So even with support to walk in dark, she feels terrible. So she also reports recent difficult in hearing. So this is where audiologists come. I think around 60% of the cases can be easily solved by audiological evaluation. If you pay keen attention on the audiological evaluation, the chances are that you can actually find a better results, are probably you can come up with a better diagnosis compared to physicians, those who do not actually recommend any kind of tests. Okay, so let's see what happened with this particular patient. So again, the first patient. So this patient, all of the patients that I'm actually representing today, represents a common journey, an average journey by the vestibular patients. If it is a hearing client, we know if they're ending up in your clinic, they don't leave. You make sure that they don't leave, right? But unfortunately, that's not the case with the vestibular patients. They roam, they meet several physicians, have multiple visits. So this is an average way. So the first, this particular patient actually had multiple visits with physician, and unfortunately, these guys, this patient has first diagnosed as positional vertigo. So positional vertigo is not a diagnosis. So that's a common way of saying that the vertigo is significant in positions, but that is not a diagnosis. Unfortunately, a lot of physicians, due to lack of awareness, they actually come up with this particular diagnosis, and that's not appropriate. And this patient is also actually diagnosed as psychogenic. The biggest concern with this patient, and probably majority of the patients, is that I think we as an audiologist and the physicians, as a team, we have to understand when to refer a patient for vestibular or balance evaluations. So this patient was not actually referred for any balance evaluation. vestibular evaluation, but was put on actually medications. Then finally, after multiple follow-ups, so this patient also was diagnosed as vestibular migraine, multiple follow-ups, this patient was sent to audiological evaluation because at later stage, this patient reported hearing loss concern. So audiological evaluation was done, but unfortunately, there was no OEEs and no speech audiometry. So the treatment went like vestibular migraine vestibular suppressants, and this patient was also fit with hearing aid because I think it started like a severe hearing loss, and so they were fit with hearing aids. Unfortunately, the patient did not like the hearing aid within the first 3 months. So she could not actually return, but unfortunately, she doesn't feel comfortable. So this is the first patient. This is the scenario, what is exactly happening right now. This patient met ENT, neurologist, even actually psychiatrist, and audiologist. So even though with these different specialists, what did we do? We could not find the exact reason, eventually led to mistreatment or inappropriate treatment, or we don't know what we are treating actually. What are we missing? We'll get to that. So let's look at the another patient. So it is 65 years old male. I use this patient every time because this is the epidemic of the suffering by a patient due to lack of knowledge, lack of awareness, and lack of specialists. So this patient started having episodic vertigo since 14 years. I think that's exactly my experience in the field. And also have recurring vertigos at least twice a year. Maximum could be 4 times a year. It is devastating actually. So oral fullness, tinnitus, and fluctuating hearing loss are some of the concerns, but not consistent. So if you are as an audiologist, I'm pretty sure that if you see vertigo, that is to recurring, oral fullness, tinnitus, fluctuating hearing loss, what gets into your mind? Menias, right? That's exactly happened with physicians as well. The patient was not referred anywhere. Just based on this, during first couple of visits, he was diagnosed as actually menias. I'll share more information. So in the initial visit, diagnosed as again positional vertigo, like a 14 years back, and we still see the same diagnosis, even though it's not a diagnosis. And then eventually diagnosed as menias by many physicians and was treated by many physicians on menias and so on. So CHAMP, again, it's a huge debatable, but I don't recommend referring CHAMP anymore. It doesn't really carry significance, and manufacturer also stopped supporting. So try not to go with CHAMP. It really don't have significance. But anyway, CHAMP was done and it was diagnosed as menias. But again, the report was really not that good. So VNG was considered multiple times actually over the 14 years. And the responses were completely fine, no abnormal responses. Caloric was not available, but was told that the client has normal caloric. So they could not find any information except for the CHAMP. The treatments is a suffering. For the 14 years, the client went through diuretics, which is the actual treatment for menias, one of the treatment, not actual treatment, and also intratympanic injections, steroids, then migraine medications, and probably a lifetime vestibular suppressants. He has a huge list of suppressants that he went through: Vertins, Trigeron, Stentil. Oh my God, I cannot explain. So he has huge number of vestibular suppressants, and obviously was fit with hearing aid. Again, no benefit. Again, this is an audiologist patient, right? So what did we do for this patient? He's seen so many audiologists, so seen several physicians, all sorts of specialists, visited many cities actually, Kolkata, Bangalore, every place that I don't think he stopped because he's a police commissioner, and he has that luxury to actually visit all the places. But he couldn't find an appropriate diagnosis, so obviously couldn't find the treatment. So let's focus on the third patient. So 36 years, again, young, vertigo, and then imbalance over the last 1 year when they showed up at our center. And the spitting sensation lost only for few minutes at each attack. This patient experienced blocking sensation and fullness occasionally in the right ear, but not consistent. It did not had a pattern. So she consulted a physician who diagnosed her with again positional vertigo. So my deepest request for my all audiologist colleagues here, if at all, if you work with any ENTs or specialists, I'm not blaming anyone here. We have a little information on vestibular, but I think we should start at some point. The first step is probably try to talk to your physicians about referring for vestibular evaluation, if at all, if they notice anything, rather than going with appropriate, probably whatever they feel like it's an appropriate diagnosis, because that can affect the entire patient's life. I'm going to show you few scenarios how it can actually affect. And positional vertigo is not a diagnosis, so please be aware of that. So this patient again have multiple visits with physician. So initially diagnosed as recurrent BPPV, but other stuff could not find a reason for dizziness apart from all those things. And this patient was put on medications and also visited, there was no help after those things. Also visited audiologist in February 2023, new patient. It was completely normal. Excuse me. In June, there is a slight mild right side hearing loss, sensorineural hearing loss, obviously. And the treatment, obviously, vestibular suppressants and monitoring for hearing loss, but no hearing aid was fit. So again, this patient did not really receive help after multiple visits by with several specialists. So let's go back and ask ourselves, what are we really missing? Why not this? These are just 3 out of hundreds of patients that we see. What exactly are we missing? So put your feet in this patient's shoes and assess yourself. What would you feel if you go through the same journey? You visit multiple doctors, visit so many specialists, but you could not find an appropriate diagnosis. Keep the treatment aside, but you could not find the diagnosis. That indicates that we are missing something, right? So let's look at the what has changed with this patient. Did we change actually anything? So the biggest reason why the patient is suffering is because how complicated the vestibular system is. As you can see, the vestibular nuclei here is actually in communication with the vestibular system, the dominant one, cervical system, oculomotor system, and spinal system. And we've also seen the other systems, cerebellar, cortical, vascular, proprioceptive, and so many things can actually affect, right? So because of this complexity, we are not able to identify precisely if you don't look at it. This is the biggest mistake many of us do. Even though you know if a patient is complaining dizziness, you hesitate to send for an evaluation, or we don't have appropriate specialists, or we don't have enough specialists. So that is the biggest challenge. Even if a physician is interested in actually sending a patient to a vestibular specialist, can they find a specialist? As of now, very, very limited. And even if you find, do we have enough knowledge? Unfortunately not. Again, I'm not blaming anyone. It is what it is. We have very limited information, but I'm very glad that the current generation professionals are actually are interested in vestibular. So that's a good sign. And the bad thing is that after the COVID, there is a dramatic increase in vestibular issues, vestibular imbalance issues. So there is a need for more audiologists. So now comes the big picture. Now we understand how difficult, how complex the vestibular system is. It's just having VNG or VHIT is not enough. VNG assesses probably your VOR system and some central system or a basic screening of vascular system, but does it? Okay. There. So again, as I was saying, VNG alone is not enough, right? So we know VNG do actually give some information, not complete information on the VOR system, probably some vascular, some cervical. Again, it's only screening, but BPPV, yes, obviously. But it doesn't give you information regarding your complete cervical, complete spinal, complete proprioceptive or integration within the vestibular nuclei. So it doesn't give you that. We never know. The reasons that you're dealing with could be coming from these affected regions. Caloric, it's a simple test, but predominantly it assesses the lateral canals, right? And we hit 6 semicircular canals, not even complete central picture. CVEMP, obviously, your colic reflexes. OVEMP, again, has a limited value, but it does have the capability of testing peripheral as well as central, but not complete picture. So you can only assess a patient completely if you have a capability of testing a comprehensive neurovestibular evaluations. But again, you can ask me, is it really realistic? No, not at all. It's very, very expensive to actually have the entire stuff, but it is not realistic. But however, we can come up with the strategies. Basic thing is you have to have basics, and majority of the population do actually have basic issues. If you treat them at the right time, you may prevent getting it worse. But what we need is knowledge first, and then the assessment tools, which is the equipment and all. So I'm going to talk about that probably at the end of the session. But as you can see, a bigger picture to find a complicated vestibular system has more. You have to assess, if you want to assess a complete balance system, these are the different tests, and there are more nowadays actually. So it need bigger scope to actually assess. So this is the reason why if a patient actually visits ENT, they try to do their best within their scope. If you send a patient to neurologist, again they try their best looking at the neurological aspects, and usually ENT sends to neurology if they don't find the reason, and neurologists send back to ENT if they don't find appropriate reason. But the actual person that should come between these two are audio-vestibular specialist. Again, I'm not saying vestibular specialist. It could be otolaryngologist considering themselves as vestibular specialist, or could be a physiotherapist. But you, audiologist, have the scope to actually expand the horizon into bigger way. But we'll talk about that later. But that's where the overall system comes in. And if we can actually introduce this particular referral system, it becomes easier not only to the physicians, but also to the patients. So let's look at the first client once again and see what happens if the same patient comes to an audio-vestibular specialist. So here I mean not a physician, not a regular audiologist. I'm very hopeful that because you are attending this webinar, I'm very much confident that you are interested in vestibular science or vestibular balance interest. You have the scope or you have the interest in it. So I'm glad you will be an audio-vestibular specialist pretty soon. But in order to become an audio-vestibular specialist, we have to understand what exactly happening and have to develop those skills. But let's see what we can do as an audio-vestibular specialist. The so many specialists could not actually help. So VNG evaluation, if at all any of these physicians could have actually referred this patient to appropriate audio-vestibular specialist or vestibular audiologist, they would actually go with a regular VNG evaluation, right? So VNG evaluation, the spontaneous nystagmus did show abnormal responses, but pay attention. Most of you are confident with the vestibular evaluation, so I'm just going to use some jargon here. So minimal direction changing nystagmus. So that indicates a possible central indicator, right? So it's a central indicator. Oculomotor testing, some abnormalities like a saccadic intrusions and delayed latencies, again indicating some central issues. And head shake resulted in square jerks, definitely some central indicators. And cervical and VBA screening again indicated central indicators. So these are central indicators. And the rest other positional BPPV is negative, and all of the came out to be normal, but it doesn't indicate any peripheral, right? So this is one of the important information. Now we know there's something wrong, but even earlier they could not find that there is something wrong. And MRI, CT would not actually, CT scan would not detect these things. It's a functional testing, right? So we did do calorics on this patient. As you can see, pay very close attention. Don't be fooled by how it actually shows. So this is 0, meaning that there is no responses. Those who know what is caloric and how to read. So the overall SPV is only 11. Even though here it shows that it's actually weaker to the left side, but the overall degree is actually bilateral absent. Both ears are completely absent. 0, almost 0. The 11 degrees, whatever that you're seeing, is because of some artifacts, but not really significant. Almost 0. Bilateral vestibular loss. And VIMS, bilateral absence of VIMS. Okay, as you can see, the VIMS are absent on both sides. Right side, we don't see any kind of N1P1. Again, left side, no N1P1. So these two are in correlation, right? And then the complexity here is that VNG is actually indicating central. If you have only VNG in your clinic, what are the possibilities of V, including me, if I only have VNG, the possibilities of diagnosing this patient as central is high, right? So many clinics I see that don't carry caloric because it's too expensive. But yes, that actually have a significant effect. But the VNG is indicating central and the caloric is indicating bilateral loss, which is a scary thing. And it's also being confirmed by the both CVEMP and OVEMP. Now we have contradiction. One is saying central, the other one is saying bilateral. It could be again central, it could be peripheral, right? Again, we are not getting to the conclusion, like what exactly are dealing with. Is it peripheral? Is it central? So we need help. And that comes from the rotary chair. So rotary chair is an amazing test, but again, not everyone have the capability. But if you have a will, you always find a way. There is a simple way to actually test. I'll talk to you guys at some other time how to do rotary chair in your own clinic in a simpler manner, but let's see how it goes. So the rotary chair has two different information. So two important information. One, the gain. The gain is normal, meaning that if I'm turning my head, if gain is normal, the eyes goes opposite way within the same distance that actually head moves. So in here, the gain is low, meaning that if the head is actually moving to the left, the eyes are supposed to move to the right, but it is not moving. It's actually almost coming with the head. That indicates that there is an actually abnormal peripheral function. If it is a low gain, that actually indicates a peripheral function. And a slow phase, the SHA phase, is another concept. I'm not here to talk about the concept. It's completely absent or a completely phase lead. That indicates peripheral. And central, the step velocity also indicates completely low gain. So this is the low gain, indicating that there is some peripheral issues. And the time velocity, time constant also shows fast decay, indicating peripheral. So now the job of audiologist or any professional or audiovestibular specialist is putting these pieces together. Because we know the vestibular system is complicated, there could be more than one or two systems that has been affected, not just one. So you have to find all the evidence that's possible and put these pieces together and understand what you're dealing with. And now we have fancy VHIT. Now you can see, I don't know how many of you are comfortable reading the graph. Here you can see this is 0.5 gain, and almost all active movements did result in a reduced uh, VHIT gain. That indicates that all canals, except for this particular one, right anterior, almost all canals has been affected dramatically. And you can still see some saccades here, right? So that is again indication of more information. It's not only peripheral, but if you're looking at these saccades, it also indicates that actually uncompensated, the patient is not compensated yet. it could be due to several reasons. So and you're looking at the odd saccades. So now let's look at these pieces separately. Caloric is indicating hypofunction, could be peripheral, bilateral, and rotary chair significantly indicating peripheral. Vents are absent bilaterally, again indicating peripheral. But however, the VNG was indicating central. So why is it central? Is it really central? No, because both systems has been affected. Basically the vestibular nuclei do not have any clue, so it is actually relying on other systems. It could be relying on let's say cervical. If you're turning your head because this is gone, it might be relying on eyes as well as cervical, and even probably other proprioceptive systems. Based on that, it might be working to make this feel a person feel little balanced, and that could be the reason why you're looking at central, because there is no compensatory movements. That is the reason why you're looking at central. So this is exactly what we need. And to look at even more precisely, we can actually go with something called sensory integration of balance. This actually helps us in understanding not just the VOR, but this actually assesses the spinal system and the integration of other systems together. Standard is combination of, so this is the standard combination. So standard meaning that the client is utilizing all available systems. The eyes are open, meaning that the oculomotor system is working fine, your vestibular system is fine, and standing in a hard surface, the spinal system is fine. So if everything is fine, you should be looking at normal responses. But for this patient, you can see the responses are really poor. And when we ask the patient to only utilize proprioceptive, meaning that you actually have them close their eyes. Once the eyes are closed, they predominantly rely on proprioceptive. So here the responses are affected again. And you also have a vision. So when the patient rely on vision, so basically you ask the patient to actually open their eyes but stand on a foam. When you stand on a foam, basically you're taking out the proprioceptive. So the only dominant system that's going to be helping this patient is vision. Because there is no motion, vestibular system is not active, so it's not contributing significantly. So then you finally assess the vestibular system. So vestibular system, basically you're going to ask the client to close their eyes, basically shutting off the oculomotor system, and stand on the foam. Basically that takes out the proprioceptive. Now the only system that's available to help preventing falls are the vestibular system. So as you can see, this patient exhibited complete absence across all other tests. So now question is, we know it's a bilateral hypofunction, that is peripheral, but why? Why are we looking at all the systems, and if all the systems are actually abnormal? So that is the question that we should ask ourselves. So let's look at, I'm not going to answer that yet, but let's look at this audiogram. So this is the audiogram. All audiologists, including myself, what do we observe? We observe a significant asymmetrical hearing loss, right? So this significant asymmetry, along with any kind of accompanying sign, it could be, let's say, tinnitus or a slight imbalance, could be potentially life-threatening. So consider it as a potential life-threatening, and take these as a red flag and try to rule out any retrocochlear pathologies. So anyway, so the again, as I mentioned, the previous audiogram did not accompany the OEs or even speech audiometry. The SRTs and WRS could not be established, meaning that we did try it, but patient could not actually generate any SRTs. Basically, the SRTs are more than 100 and WRS is 0. Basically, does that match? Does that correlate with the audiogram? No, that's again a red flag. The sputum audiometry and speech audiometry are not in correlation. And let's look at this DP OEEs. Isn't that amazing? Right? You have almost profound hearing loss on the right side and moderately severe to severe hearing loss on the left side. Boom. The OAs are absolutely normal. What do you think? right? That is exactly what we have. There are so many pieces that doesn't actually come together if you look at them piece by piece. This is exactly the issue. If a patient goes to the ENT, they look at their own specialization. If a patient goes to neurologist, they look at their own specialization. Audiologist, only audiologist, you look at your own audiology aspects. No, that's not enough, because the vestibular and balance system are pieces, and we have to put them together to come to a conclusion. This is not a random patient. This patient had a Friedreich's ataxia, meaning that this patient actually have a decaying or diminishing neurons. So basically, the neurons are actually slowly diminishing, but the peripheral sensors are amazing. That is the reason why you see normal OEEs and probably other systems that are actually working. But unfortunately, the neurons that carry information, both from vestibular system as well as auditory system, has been affected. And upon verification, after this testing, when we asked, the client also indicated that she's losing a vision. That's another sign in the Friedreich's ataxia. So again, go back, revise that this patient visited multiple times, multiple physicians, was put on several medications, but never referred for VNG, right? So this is one of the important patient. And again, now with the combination of all these, you can change the life of this person. So what's the treatment strategy? Again, as of now, for this particular patient, she's actually going through a lot of vestibular suppression. That makes it even worse, because whatever the left sensory information is being suppressed by the vestibular suppressant. So we're trying to actually limit that. And basically, there is no proper cure for Friedreich's ataxia, but we are actually trying to overcome the vestibular issues by utilizing other sensors. And main intention is to prevent any fall so that there's no life-threatening issues. Okay, so now let's look at the second one, the 14 years patient that suffered a lot. So let's see if he visits an appropriate audiovestibular specialist. Obviously, we go through VNG. You can see there's a lot of abnormalities, minimal right beating, and minimal right beating, even with head shake. Those who have knowledge in vestibular, you know if there is a spontaneous lateral beating, meaning that that could be potentially peripheral and uncompensated. And if it is significant with head shake, you know there is a uncompensated vestibular issue. But however, remember that this patient is suffering with this issue since 14 years. There is no way that if it is truly peripheral, it could be compensated. And calorics indicated left side weakness by 67%. Again, since 14 years, no proper treatment and no proper diagnosis. So further evaluation, CWIMP also indicated there is a left side weakness, but VHIT is completely normal. Rotary share, does that make sense? Caloric is weaker and the WEMP is also weaker, but VHIT is actually normal. So that is something that we have to look into. So meaning that these two are not actually correlating with each other. The rotary chair here is high gain. That is indicating that it could be central issues, but probably not peripheral, or probably some compensating. But in previous tests, we know that it is not actually compensating yet because it's significant. So this is another contradictory information. But step velocity is actually indicating fast decay, meaning that it's a peripheral. So lot of conflicts there. One test is actually indicating central, the other test is actually indicating peripheral. ECOG came out to be completely normal. But remember that this patient has been actually diagnosed as Meniere's and has been treated for years for the Meniere's. Okay, these are the audiograms. You see the beginning, the thresholds are fine, and then it eventually gotten worse, right? And patient also feels a fluctuating hearing loss and on the left side, and also mentions about pulsed tinnitus, some oral fullness with episodic vertigo. Doesn't it sound like Meniere's, like a fluctuating hearing loss, tinnitus, oral fullness, right? But however, the ECOG was completely normal. What could be the reason? Again, there is an asymmetry. Asymmetry in audiological evaluation is very, very important. This is the reason why I mentioned at the beginning, audiologists can identify the vestibular issues are beyond the audiological issues at least by 60% of the time because of these asymmetries and other signs. Please do audiological evaluation, Putin audiometry and speech audiometry, and compare them. You'd be amazed to see the difference that you can contribute in differential diagnosis. So asymmetrical hearing loss and speech audiometry is definitely worse. There was a poor WRS scores only by 54% on the affected side. Again, a red flag, right? So what are the red flags? The significant asymmetry, worse WRS scores, pulsatile tinnitus, and high gain in rotary chair. Basically, they do not match to each other, indicating that there is actually retrocochlear involvement. Even after multiple medical physician referrals, we again decided to send this patient to medical physician. But this time we know which imaging to look at it. So we specifically referred to actually go with um, MRA, and then we got the responses. So let's put all these pieces together, and it is obviously left vestibular hypofunction, but the MRI came out that there is actually vascular. Again, we decided to actually send for an MRI, and we found out that there is actually vascular loop between the internal artery canal, and that is the reason why there is these issues that's happening since 14 years. So what are the treatment options? Were there any improvement? Obviously, yes. The treatment options were that he has to see vascular specialist now because that is the culprit. So we have this patient on blood thinners and cholesterol medications and under observation for vascular decompression. So vascular decompression surgery is not common, especially in India. So this patient is still waiting on any of those help actually. So vestibular rehabilitation to promote balance, and obviously the progressive tinnitus management for the tinnitus issues, and a change in lifestyle. Basically, there is a compression of the vascular loop on the auditory nerve. So we try to prevent any further compression. So one of the important instruction to the client is that they're not supposed to compress the neck because that can result in increased vestibular or probably auditory outcome. So before this particular diagnosis and treatment, the DHI scores, the dizziness handicapped inventory, was 72% after 14 years. But after this, just 32%. You can see how dramatically the scores were gone. And they were not on any medications except for the blood thinners or cholesterol, right? So the last one, again, there's spontaneous nystagmus, and all other were completely normal. Positional indicated some non-significant right beating nystagmus. Again, minimal right beating and the spontaneous and positional right beating nystagmus, there is a correlation and it could be peripheral, right? And the caloric now is indicating that there is actually weaker. The image is wrong, but sorry, the caloric is actually normal. It's a 13% weaker, but it's not significant. So overall, we really do not have enough information to say if it is actually significantly affected or not if you go with only VNG. So if you add VEMP, now you can see that there is no response on the right side, whereas there is a reduced response on the left side. It is not significant, but 50% difference. That is a significant information, indicating that the right side is actually affected. Okay. So again, we seek the help from the rotary chair. It is actually showing the low gain, again indicating peripheral. That's a good sign. And phase is being fluctuated, but it is phase lead. And with step velocity, the gain is normal. So that indicates that it could be a compensatory effect, or probably there is no significant peripheral. But the uh, uh, time constant is indicating weakness on the right side. So you can see there is actually asymmetry in the step velocity leading towards the left side weakness. So So further evaluation, what did we do? We send this patient to rule out there are any other central involvement because of uh, conflicting information. So we sent for a HRCT, and it came out that this patient have a right petrous apex effusion. So what does it mean? So basically, there is a fluid buildup within the cochlear region between the cochlea and the brain. So basically, this is similar to like the air cells within the middle ear are filled up with fluid. So that can actually compress the cochlea and have various effects. Sometimes it could be only auditory signs. Sometimes it could be combination of tinnitus, auditory signs, or abnormal vestibular function. But unfortunately, with this patient, she has all together. So again, only one or couple of tests is not enough to come up with a diagnosis. You have to look at the overall picture to understand what exactly that we are dealing with, right? So you can determine based on this whether if it is central. If it is central, you have to understand where it could be coming from so that you can help the physician in identifying which particular test that you might be requesting. So the appropriate diagnosis after the entire evaluation is the right vestibular hypofunction secondary to the right petrous apex effusion. So what is the treatment option? So basically, this patient has to monitor with an ENT to actually go for a surgery to remove that infection out. We don't want to let this infection spread any further. But this patient is actually from US, so this patient felt comfortable actually going to US and then have treated there. Okay, so that's the overall concept of vestibular system and the existing scenario for the patients and where we stand as an audiologist. So what are the treatment options? Let's first look at this. The traditional method is actually vestibular rehabilitation. So it really helps several patients, majority of the population, but some patients do need to be put on actually medications, not on vestibular suppressants. Vestibular suppressants must be prescribed only for the first couple of weeks, but not more than that. There's a lot of study that actually indicates the adverse effects of vestibular suppressants. So again, if you work with any ENT, please do discuss with them and let them know that the prolonged recommendation of vestibular suppressants can adversely affect the patient. Again, surgeries and counseling, and there are more ways. A combination of treatments must be given. So again, as I said, even with proper diagnosis, if you send back this patient to the ENT without educating the ENT first, or even neurologist, the chances are that they're actually still prescribing the vestibular suppressants, even though this patient need to go to the vestibular rehabilitation. So 72% of the patients who need vestibular rehabilitation are still under the vestibular suppressants. And only 28% were actually given to go for the vestibular rehabilitation, but relying on the brochures or YouTube videos, but not in person. That also affects the outcome. So now the overall point at the end of the session, what exactly the role of audio-vestibular specialist? So now we've seen how complicated the balance system is, right? It talks to too many sensors, and it can be affected easily by any of those sensors. And we also know each specialist only works in their area. ENT within the ENT, neurologist within the neurologist, general, probably some BP, sugar, all those sort of stuff. But what about the others? Who is going to take care of all of these and look at all of these at particular spot? You as an audiologist carry additional skill apart from these guys. So that is the reason why there is high need for audio vestibular specialist. Being just an audiologist is really not enough. This is the time that we should kick up a little bit and actually pursue a little interest in vestibular specialization, because believe me, it's going to be the future in very short time, definitely, considering the existing market and the amount of the increase in vestibular issues that we see. You're definitely going to have a lot of vestibular patients in near future. So what is the role? What can the audiovestibular specialist show the difference? What's the difference? It can actually show a life-changing difference. And all we need is vestibular specialists. And why no improvement so far? Because of misdiagnosis, and the core reason is that we really do not have enough specialists. What are the treatment options? Again, it depends. It depends based on the appropriate information, appropriate treatment, right? So that is exactly what we need. This particular vestibular issue can be overcome just by learning where the issue is and understand that brain is too intelligent. It doesn't rely on only one particular sensor. If vestibular system is gone, it has the capability of ignoring vestibular system and can actually rely on other sensors to make you feel almost normal. This is vestibular rehabilitation. And unfortunately, we are not putting patients on vestibular rehabilitation, but unfortunately, the patients are on vestibular suppressants, which suppresses other systems as well. So the patient has issue, and now you're actually introducing this vestibular suppressants for prolonged period, and you're letting them actually suppress the other issues. What happens? The result is your brain is learning this negative effect, and it becomes constant and becomes psychogenic. That is triple PD. The improper treatment is leading to more complicated issue, which is triple PD. So that is exactly what and where the audiologist should shine up now. That being said, what exactly that we have? I'm going to be very quick here. So I haven't talked about efferents. I'm pretty sure that none of you know anything about, or any of you know anything about efferents, because we know very little about efferents. But unfortunately, fortunately, that was my area of interest. So the good news is that we found a medication in animals. It's not a suppressant. It doesn't act on the brain, but we found that the efferents actually have the capability of stimulating the lost. So this is the sensor that we actually took out from the live uh, uh, mouse, and then we actually injected drugs into it and see what happens. So we found that there is a GABA B channel. If at all, if we actually stimulate them, then it can actually act like a normal one. So to do that, first we actually took out the sensory epithelia, and then we injected into the intratympanically and see how the rats actually work. So we've seen amazing responses, and it's easy. So you can see that this step is food plate. We actually injected the drug directly into the cochlea and see how it works. So the results are actually amazing. But unfortunately, it takes another 5 to 7 years to come on to the human trials. But if at all, if it can come out as we've seen in animals, there might be good news pretty soon. You probably might have an appropriate treatment to the peripheral issues, not probably other issues, but to the peripheral issues. Okay, so that being said, that's all I have for this particular course. I hope I gave some insights that could be helpful for us, me being the audiologist, help in understanding how much we are in need of the vestibular specialization. So I always say that there is a need now more than ever to produce more audio vestibular specialists. And I'm very hopeful that you guys will be one of the primary people to adopt the vestibular services as soon as possible. So if you have any questions, please do shoot email at this particular email. We'll try to respond as soon as possible. And now I'm open for any question and answers. So if you have any questions, please do ask in the Q&A box.
So we have got few questions on Q&A.
Okay.
The first one is difference between dizziness and vertigo.
It's a good question, at the same time basic question. So vertigo is a specific definition, right? So vertigo, you only refer it as vertigo when a client truly feels like spinning sensation. And you should see nystagmus significantly if it's an uncompensated. That is a vertigo. So dizziness is a broader spectrum. You can actually include everything in dizziness. If it's not like a spinning sensation, then yes, you can actually consider it as a dizziness. But again, dizziness can be further elaborated. People can actually refer it as a lightheadedness when they feel like really light or like a floating sensation, or even swaying, all these things comes under the dizziness.
A recurrent vertigo attacks. It is just mentioned as recurrent vertigo attacks. Hello.
Yes.
So
Recurrent
can you
vertigo
please
attacks.
Yes, yes, sir.
Yes, so the recurrent vertigo attacks, meaning that the vertigo keeps on coming. Probably today I have an episode of vertigo. I might be fine for next 1 week and then it comes back. So this phenomenon can be observed in multiple disorders. One of the common way to actually see is in actually menials. That's an episodes, recurrent episodes. I get the episode probably now, and I might get another episode in 6 months. But in between, I'm completely free of symptoms. And this can also observed in actually BPPV. Some BPPV can be recurrent. It's again a vertigo. It's a true spinning sensation. That could happen in BPPVs as well, and some vascular issues may also actually accompany as recurrent vertigo attacks.
So other question we have, can you please explain about VBI and cervical evaluation?
Absolutely. So the cervical is you're trying to evaluate and see whenever that you compress this colic reflex or the cervix, the neck, if that actually induces any dizziness or lightheadedness or even like imbalance. So the intention is to see if there is any cervical issues. It could be like a spondylosis, or probably some people have actually have strong muscles, stiff muscles that can compress the arteries or probably nerves that's passing to the brain. If that is the case, then it is actually cervical. The same test, so the cervical screening is very simple. You actually ask the client to turn their head all the way as far as possible, usually at least 45 degrees, and have them in this position for few minutes, few seconds, not minutes, my apologies. That could result in some people, those who have cervical issues may actually feel dizzy, and you might see the nystagmus if you're using the VNG goggles. The same test can actually assess the VBI is vertebrobasilar insufficiency. So this is specific to the artery. If an artery is actually passing here, the carotid artery or basilar artery, when you actually turn the head for VBI screening, the chance are that it might be actually compressed. If it is compressed and if it is blocking the flow of blood to the brain, basically you're blocking the oxygen to the brain, so it gives you a significant signs such as like lightheadedness or slurred speech. So those are the signs that you can easily actually identify if there are any chronic artery issues. But it's not consistent every time. But if it is chronic, yes, you might be able to actually find this test. So one of my biggest recommendation is that anytime that you go for BPPV evaluation or management, I would highly recommend going for VBI, because you never know. Sometimes the vascular issues might actually mimic like BPPV. So if you actually have the client be in that particular position for a prolonged period while during the management maneuvers, the chance that you're actually compressing the arteries as well, that can adversely affect the chance that you might actually induce a stroke. So you have to be very careful in that particular aspect.
And the next question is difference between vertigo, spinning sensation, and dizziness and giddiness.
Difference between vertigo, spinning sensation, dizziness, and giddiness. So again, as I said, we
Giddiness.
can categorize this into two ways. One, vertigo. Vertigo is a true spinning sensation. Dizziness is a broader spectrum. Everything comes under dizziness. It can be imbalance, lightheadedness, floating. All these can actually come under the diagnosed dizziness.
For the second case, ICA loop, AICA loop in VNG hypoventilation test, was it positive?
It was minimal. It was not significant, but definitely minimal. Thank you for the question.
Can
Yes,
an
the
individual
recording
who
will
has
be
studied,
available.
yes, um, how do you see psychological referrals in vestibular issue and how to decide when a patient needs it?
It's a very, very good question, actually. So, psychological referral must be at the end, but it could be one of the important aspect. But the question that we should ask is why psychological, right? So, the psychological referral is important or required when you actually looking at the triple PD, but the triple PD may not be completely recoverable by psychological counseling. So it does need some advanced vestibular rehabilitation, and in certain cases, there are very stubborn patients or very chronic observation. These people might need some counseling. So yes, these people might need, but first, before you actually decide, you first need to evaluate that the patient do not have any organic issues. It could be either vestibular, it could be cervical, it could be ocular. You have to make sure that there's nothing abnormality. If it was, then it must be treated first, and then you probably might need to consider the vestibular sorry, the psychological aspect along with the vestibular rehabilitation. But never judge a patient based on their hyper exaggeration about the signs, because the vestibular signs are very dramatic and it can be worse that we cannot be explained in words. So they tend to be feared. They tend to have a lot of fear even to do anything. That doesn't mean that they have psychological issues. They suffered, so they have psychological issues. So you probably might need to consider that very carefully.
Can an individual who has studied AUD can practice in Australia and the UK?
Yes,
Uh,
absolutely. If you have
Venkatesh.
AUD degree, and that will be accepted at in any country, and you probably might have additional weightage to your again. I lost. I hope I answered that question.
Yes, sir. As one cannot have all the tests, which tests do you think would be the most important ones?
So that's a very important question, actually. So you really don't need the entire aspect, but you have to understand how the system works, right? If you understand that as you test, if you only have like a VNG, if at all, if you find some issues and based on the symptoms and with your audiological evaluation, you could further identify. But usually around 60% of the time, you just need VNG and caloric. But for advanced, unfortunate advanced complex issues, you probably might need more equipments. But this is where the referral system to actually should come in. So you do most of the tests and identify 60% of the population and treat them, but like a 20 to 30% population might need advanced testing. For them, you could actually refer to any known nearby centers to actually go for further evaluation, but not necessarily have everything. It's too expensive to even maintain.
So, can you please explain the diagnosis of positional vertigo and also vestibular migraine?
So again,
Is
positional
related.
vertigo, I don't consider it as a diagnosis. So earlier we used to say like positional vertigo, indicating that the vertigo is consistent whenever there is a change in position, but that's not diagnosis. You have to understand why and where it is coming from, why the vertigo is existing in each position. Is it because there's a vascular issues, or probably BPPV, or even uncompensated vestibular hypofunction? That is the reason to find out. That is the diagnosis. So yeah,
So, what are the areas with maximum scope of research in vestibular audiology today?
plenty. Plenty. So depending on your interest, so vestibular is vast, and I think you can work on anything, definitely. But I
How to
work
learn
mostly on
proper,
electrophysiology, as well as some efferents and some complicated cases.
yes. How to learn proper interpretation of VNG?
Very good question. I think the answer is first we have to understand the basics, and then the second you need a lot of at least good amount of exposure and some supervision. So it initially it can be very confusing because nothing is straightforward in vestip. Everything it changes. In audiological evaluation, we know that 0 to 25 is null, no matter what, or probably 26 to 40 is mild, no matter what. But that's not the case in vestip. Sometimes it might look like peripheral, but it could be ending up as actually central or vice versa. So unfortunately, I do not have a straightforward answer. You have to have a better understanding of vestibular system and have some exposure, and then you'll eventually gain that knowledge, and the interpretation becomes easier for you.
Does the MSc Audiology course train you appropriately for being an audiovestibular specialist?
That depends actually. Definitely depends, depending on your institute, whether if they have a good vestibular program. But as of now, including US, not all universities have established vestibular courses or training. So that's the case. But I cannot really answer based on your institute.
So, is it true that dancers and athletes have better vestibular reflexes?
Very good question. I'm actually doing a research now, and athletes and cheerleaders right here, and we already see that they have advanced vestibular responses. And whatever the normative value that we have is not actually appropriate for them. So we are actually working on that. We are coming up with the new normative values for these people.
So, one participant has been thanking you for your excellent information, sir. And also, the
Thank you.
question is there any preliminary checklist an audiologist can perform in which is quick, sensitive, and indicative of tentative central or peripheral lesion?
Yes, there are several. Like the functional tests are completely appropriate. You really don't need to have a complicated or expensive equipment. But yeah, there are several functional tests actually that you can basically start with the Romberg, and you can do even the SIB just in your clinic. Just have like a foam pad or even like a couple of pillows. You can easily do it, and that eventually help you in understanding whether if it's actually central or peripheral, even if it is proprioceptive or probably visual based or probably the vestibular based. It will definitely help you. We could actually go for we'll try to plan a webinar on these functional tests probably at some point, so that we'll have a better understanding on these things.
The next question, how the vestibular system different in autism spectrum disorder as they are hyperactive, they jump for a long time, swing ahead, and there are some who won't experience any vertigo or dizziness. So how is the vestibular system different in ASD?
That's an actually amazing question. We tried to actually look into this particular aspect. There was not enough research because in our clinic we have a patient, one hyperactive, obviously diagnosed as autism with ADHD, but this patient kid actually tend to fall more frequently. So we did a couple of testing, pediatric testing. We found out that there is actually some vestibular issues. So the idea, as we just learned, the vestibular system actually have a connection to the cortex. And if there is any abnormal functioning that includes any psychological aspects or probably cognitive aspects may actually have an effect on the balance. Not necessarily vertigo like falls and all, but balance. But amazing thing with the pediatrics is that because the brain is growing, this it's still actually developing. If there is any issue with the vestibular or any other system that actually helps in balance, it can overcome that by utilizing the other sensory system. So that is the reason why in pediatrics, unless it is chronic vestibular or balance issue, they usually overcome that. So but it's a very good question. So that's the reason why even if the autism spectrum disorder people may have some balance issues, they might not actually exhibit it because the other systems are being compensated.
Uh, Cochlear hydrops analysis masking procedure is used in which instrument recently?
No, the only manufacturer that was producing is, I think, let me let Autometrics. That manufacturer has stopped producing it, and no other manufacturer recognize it, and no one actually develops it. So you don't have it, basically.
Is there any publication article on intracochlear injection method?
Yes, I we have published in, I think, Neuroscience. Yes, it is available, and it is continuing at State University of New York and Johns Hopkins.
So here we got a request like, "Hi sir, I'm private clinic owner of hearing and speech, and I'm now interested in establishing vestibular setup at my clinic. Here my question is that would I have an opportunity to collab with Rasya, or would Rasya help us in setting up with vestibular unit at our clinic?"
Absolutely, yes. I think that's something that we are working on, not only with like a private practice owners, but with students as well. So we definitely need a lot of vestibular specialists, and we definitely need a lot of vestibular clinics. And if there are like any people that are interested, we have many plans and support a team to actually help you out in not only establishing, but we can train you. In certain cases, we can even provide you an expert that we already trained to your clinic.
How is caloric test used for differential diagnosis?
Uh, so that's a very important question. But again, understand that the caloric test may eventually fade out, meaning that it might never be in clinic anymore. One of the reasons is that the caloric has less significance. It eventually tests obviously the lateral canal, peripheral, and there is like directional preponderance, which is considered as probably some central. That's the majority of information that we get from it. But only caloric may indicate that there is actually weakness, hypofunction. But again, the same caloric may have abnormal responses in retrocochlear, because the information is not being passed on to the higher level. You may see the same responses, but apart from that, you may not really get enough information. That same response can be actually achieved by lateral activation of the V hit. It's better than caloric actually.
Are audiological tests, behavioral tests, and WEMP enough for diagnosis?
For audiological, sorry, vestibular,
Audiological tests,
no and
behavioral
yes.
tests, and WEMP enough for
No and
diagnosis.
yes. It depends. Some patients, yes, I think that's more than enough. But again, depending on the complexity, it might not at all actually enough. So you have to be very careful. So it's better to start with nothing rather than not starting at all. So that's the reason why I mentioned that if anyone interested, you can actually learn the basic functional test without any equipment. You can actually have a just pillow on the foam pad. That's an amazing test actually. But if things looks complicated, then you have to make sure that you have to refer this patient to a center where they actually do this, because it's a patient's life. Things get worse and it can destroy a person's life. So try not to withhold this patient. But yes, you can actually start with these three things. Absolutely.
Is doing only CWEMP and ignoring OWEMP lead to misdiagnosis?
Not necessarily, but sometimes you do need both. And again, that information, if we have VHIT, that could be a great tool to understand whether if you really need OWIMP and CWIMP. But if you have it and if you have time, I would suggest to actually go for both.
How much importance we can give to case history, and how to take proper case history and move further based on it?
So I would say case history is the biggest that carries like a biggest importance. uh, Not rotary chair, not VNG, not VHIT, nothing. If you don't have proper case history, nothing makes sense in vestibular. So that's another thing. So practically, when you actually specialized as an vestibular specialist, you would go back again and again and ask patients more and more questions, because as you see results, you have to correlate what patient is actually experiencing. So yes, the in vestibular, case history plays a biggest role in diagnosis actually.
Giddiness comes in triggering factor or spontaneous?
It can be spontaneous. It could be triggered by several factors, such as like a neck pain or probably even migraines. Yeah, it could be both.
Is there any flow chart to decide based on case history which test to administer?
Yes, there are some tools actually developed by several institutes where you can actually have questions filled. It's like a questionnaire, and based on the responses, it will help you in identify. But again, it's not diagnosing. It will help you in identifying certain tests. Probably help you in identifying what could be the possible reasons.
Does RASIA provide vestibular course for audiologists? Do we have any learning counter to gain intense knowledge on vestibular system, its diagnosis and treatment with hands-on practice?
Yes, as of now, we recently established are offering a course exclusively on vestibular training. It will be focused only on audiologists. So I think we all understand that there is a difference, the way that ENTs approach and audiologists approach. So we identified that there is a gap and there should be a course from audiologist for audiologist. So we did develop a course for audiologist exclusively, and yes, we have theoretical materials, and we focus mostly on the hands-on training because I've seen so many people do feel comfortable theoretically, but when it comes to administration and interpretation, a lot of us still suffer. So we focus on that.
Can you please put light on vestibular implants in your experience?
So vestibular implants is still a very new concept, but the early researchers are actually indicating very good responses. But again, it has a lot of complications. I think it might take few more years to actually come to be easily available to the general public. So it's too early in this particular at this particular point of time.
So the difference between BPPV vestibular neuritis and vestibular labyrinthitis based on history and also tests.
um, BPPV, again, it can be purely positional, and it could be like only one-sided. If they feel like they feel spinning sensation only at certain angles, but completely fine in other angles, or when they don't move, so that could be BPPV. And the neuritis is probably, let's say, sudden vertigo, probably prolonged for a couple of minutes to hours, and then eventually it becomes dizzy. They feel dizzy whenever they move quickly, but not like every time, or have difficulty in walking, uneven surface, or these things can be vestibular neuritis, and it could be sudden. The the labyrinthitis is, it could be neuritis but accompanied with hearing loss, meaning that both hearing as well as vestibular senses will be affected. The interesting aspect with the labyrinthitis is that because hearing loss is considered as secondary compared to vestibular issues. If someone actually have vertigo, you don't know how it feels. So everything comes second, meaning that if it is a labyrinthitis, patient feel vertigo more intensely compared to the hearing. So people don't notice that they have hearing loss at that particular point. So yeah, but the best thing for neuritis and labyrinthitis is that sometimes it could be actually recovered. The best option is that send to an ENT as soon as possible so that they can actually work on it. But they must come back to you to look into audiological as well as vestibular aspect, so that you have to give rehabilitation as well.
Can MWEM be used for clinical usage or is it still under research?
I think we need more research before it goes to clinical evaluations. It's still, again, very early. Not many people are aware of it. Yes, it's still in early phase.
Session was very helpful, sir. Can we expect more webinars in future?
Definitely, we are working with a few organizations and institutes to create awareness in vestibular at the same time to help understand these. So yes, if you are interested, we'll be definitely coming out with more webinars. You can actually check out our website for more webinars.
Which domain in vestibular can be explored for a thesis?
So again, it depends on, depending on your interest. Let's say if you have interest in electrophysiology and then vestibular, then that's something that you have to focus on. Or if you have interest in, let's say, rehabilitation, then again, first you have to narrow it down depending on your interest, and then depending on your let's say, advisor. They can only advise you if they're actually sufficient, they have sound skills in those things. So all these things actually matters. So I really don't have straightforward answer, but I think it's a one-on-one discussion to help you out.
So, can you please explain briefly about vestibular migraine, signs and symptoms, diagnosis, and treatment?
So this is important
Again.
question. I forgot to actually include this in the presentation, and thank you for asking this question. So one of the biggest misdiagnoses that we've seen, like a large misdiagnosis that we see, is vestibular migraine. If you don't find anything, physicians, including us, audiologists, are very comfortable to call it as migraines. So we have to understand how this works. So understand that it's a cycle. If there is a vestibular lesion, there is a vestibular insufficiency to the brain, and that leads to the triple PD or stress. The stress leads to actually the headaches. So sometimes the vestibular lesions can induce headaches. That is the case if you don't treat headaches properly, and if you keep on visiting neurologists for headaches, they will actually diagnose you as a vestibular migraine, and you will be on wrong medication for prolonged period, which first case you don't need any kind of medication. But in order to diagnose it as a vestibular migraine, first you have to rule out whether if there is any lesions in any of these balance contributing sensors, and then find out what are the triggers for migraines. Usually most of the migraines comes with triggers. Sometimes you can actually manage them. That can actually reduce the vertigo as well. So it's a cycle. So I really do not have a direct answer to you. The basic thing is, first make sure that there is no involvement of peripheral or central issues in vestibular system, and then the migraine. If everything is fine, and if it is only migraine and it has triggers that's non-relevant to the vestibular system or balance system, then you can actually diagnose them as vestibular migraine. But okay, sorry about that once again. But you have to be very careful whenever you're about to diagnose as vestibular migraine.
So, does it follows Barney Society recommendations for this all?
Yeah, if you can actually follow the Berenice Society recommendations, that would be yes, and those are the one of the recommendation from them as well. So yes.
So, can we understand that an impact in football players and non-players by doing VNG to understand if there is any relation with their eye movements or postural stability?
No. So VNG do not have, let's say, set of normative values, meaning that if you actually test me, let's say if I'm complete normal, if I'm normal, you don't see any nystagmus, right? But if it's an abnormal patient, you're going to see nystagmus. The idea is that the athlete is going to be better than me, and I don't actually show any kind of nystagmus, then what happens to the athlete? So you won't be able to find anything. But the test that you can actually do to evaluate the advanced vestibular function in athletes is some objective testing, such as like a rotary chair, which has a significant normative value, and VEMS, that could be one of the thing, and probably VHIT, and then some CDPs, computerized dynamic posturography, and probably SIBs. All these things can be more objective in terms of quantifying the results. VNG would not actually give you quantification.
Is there any checklist to know which canal is involved in peripheral lesion?
Yeah, so VHIT could be easier if you can actually go with that.
Checklist, sir? Any checklist?
Oh,
Oh,
checklist. It's
huh.
difficult. So basically, you have to
Yeah.
understand how it works. But even without VHEAT, if you know how the LARP, RALP, and lateral actually works, and if you're suspecting there is actually issue with the naked eye, sometimes you'd be able to see and identify. But again, you need some practice on it. But checklist, no, it's really difficult. But you do have to distinguish between BPPV versus neuritis, but it's really difficult to identify which uh, canal on each particular side. That's too specific.
So, can you provide information on when to prefer OVEMP and when to prefer CVEMP for diagnosis?
So it's a very good question. Let's say CWIMP is a dominant one and predominantly used because of its quality of recording. It's bigger and not many artifacts can actually affect. But understand that the CWIMP is actually evaluating the saccule as well as the posterior canal only through the inferior branch of the vestibular nerve. So if you're suspecting that there is an actually issue with, let's say, left ear, complete left ear, because the CVMP is the strongest responses, go with CVMP. If CVMP is present and if you're still suspecting that there is actually some sort of vestibular peripheral issues, you have to evaluate the superior portion of the nerve. So that will be through the OVMP. And OVMP will be able to assess and then can give you whether if the superior branch is actually affected or not compared to the OVMP. Sometimes the schwannomas or tumors may actually affect only certain portions of the nerve. It could be either like superior portion or probably inferior portion. If you see any red flags, I would say go for both because you never know. We cannot just assume that if CVMP is good, OVMP could be good. So we cannot assume. It's better to go with both.
Do all patients with normal central pathway have normal VNG results for central tests? Frequently, I encounter VNG outputs for saccades, smooth pursuits, and optokinetic tests are not within normal limits. What might be going wrong with the procedure?
So this could be a various due to various reasons, and yes, it does actually happen. Those who have a normal vivo or function, and that could be if it is, let's say, oculomotor tests. It could be probably coming from, let's say, cerebellum or even like some central issues. Sometimes lack of proper instructions, test error basically. Sometimes a patient have active migraine or probably uh, lack of sleep, lack of attention. All these things can also actually result in this. But if these responses are significant, I would actually ask you to pay more attention during VNG. And if you see if there are like any significant central indicators, then you have to make sure that the client actually is ruled out for any central involvement.
If a patient have hearing loss with dizziness, then what will be our approach to treat?
So best way is don't fit hearing aid yet because sometimes that can make things worse. If both are accompanying at the same time, it's better for to go for audio vestibular evaluation and rule out that there are no central issue, meaning that there are no retrocochlear issue, and then you can actually go for hearing aid and then vestibular rehabilitation if there are any peripheral issues. That would be the optimal way to actually proceed with in this scenario.
In individuals with unilateral sudden hearing loss, once the hearing issue are dealt with, do you think it is necessary to educate and evaluate through it's not the major concern of the patient?
No, it is still the major concern. So even after sudden hearing loss, so you're talking about hearing loss or vestibular issues? I'm sorry.
They have asked only about unilateral sudden hearing loss.
Okay, unilateral sudden hearing loss. Let's say if you're only asking about hearing loss, then yes, once it has been taken care by the physician within the appropriate time, and if there is no possible recovery, then the next only remaining option is actually hearing aid. But again, remember that when you actually fit hearing aid, you have to be very cautious with these kind of patients, because even when you're actually fitting the hearing aid, probably after 1 week or 2 weeks, there might be still a recovery time left in that you might fit a hearing aid today with a gain of, let's say, 20 dB, and there might be recovery of another 2 dB in the next 1 week. So the hearing aid can become like louder for them. So the best suggestion is that have this patient come in for frequent visits and program the hearing aids appropriately so that they feel comfortable. But if you're talking about vestibular, so same thing goes here. if it's taken care by ENT, the steroid injection or whatever the treatment that they prefer, and they come back, they still must go for vestibular evaluation because it doesn't completely recover. So you have to find out what is the loss and where is the loss, and based on that, you have to put this patient for vestibular rehabilitation. Otherwise, the chances are that this patient might actually eventually end up with a triple PD, and that becomes even worse.
Can you suggest which is the best equipment for VNG?
So you're asking me the equipment manufacturer. If it is equipment manufacturer, that could be diplomatic. I prefer interacoustics and Inventis as of now for various reasons. But again, you might find other equipment fine.
Is there normatives developed for dancers for VHIT?
Normative developed for VHIT? I don't think so. I'm not working on dancers, but I'm working on athletes with cheerleaders. I might be able to come up with something, but we need large number of data before we publish.
Can you please explain what is noise-induced vertigo, the causes, and whether it is actually physiological or psychological?
So it could be both actually. The noise induced is a bigger term actually. So let's say if someone have actually migraine and migraine is actually causing vertigo or dizziness. Some people are very sensitive to sound, like a phonophobia, right? Whenever like they hear loud sounds, it can actually trigger the dizziness or migraines. So this is one way. The second way is that sometimes a patient might actually have a third window, such as superior semicircular canal dehiscence or perilymphatic fistula. Whenever they hear loud sounds, that can actually trigger the vertigo as well. So yes, it actually changes, but yes, sound can actually induce this. But if you're specifically asking for noise, such as like a noise-induced hearing loss, I'm afraid that I I haven't I'm not really completely aware of that. But these are the things that can be induced by hearing sorry sounds. But I'm really not sure about noise-induced.
A 21-year-old male with complaint of giddiness with nausea and tinnitus, PTA results indicative of moderate sensorineural hearing loss in right ear and minimal loss in left ear. Normal ECOG results in both ear and negative glycerol test. The ENT has diagnosed patient with Meniere's disease. Kindly share your views on this, sir.
So, very good question. So again, here the patient have like a dizziness and nausea and tinnitus. Patient, sorry, the PTA results has asymmetrical hearing loss. So whenever you see asymmetry, you must have a red flag. That's a red flag, right? And the ECOG is fine. So it is present, which is good, indicating that there is no significant meanness. But again, understand that the ECOG will be actually absent when you test during a resting phase because there's no fluid pressure within the cochlea. So that is the reason why you have to actually have this client when there is closer episode. But if you're sure that you had this test done during a closest time to the episode, and if you rely on the ECOG, I would say it's not meaningless because you do not have enough evidence. ECOG is absent, glycerol test is negative. That is not meaningless. I would say because there's an asymmetry, go for ruling out retrocochlear pathology. That's the best thing to do.
So they were thanking you for and also expecting more webinars, sir. And
Okay.
also the first question they have asked, shall we get any certificates for attending this webinar? Currently, we haven't planned any kind of certificates for future. Maybe with the support from Yugandhar sir, maybe we can do it. And
Yes,
few
yes.
more questions they have mentioned in the chat box that I think I'm just checking. Tests other than VNG.
There are a lot of tests other than VNG. I think VNG is highly overrated. but it is very important, because it is a little inexpensive. You can actually go with VNG. So V heat, CVEMs, OMs, rotary chair. There are like a DVA and some balance testing, such as like a sensory integration of balance and sensory organization test as part of CDPs. All these actually comes, but again depends on what kind of patient load that you have. So if you are actually dealing with complicated patients, dealing with neurologist and audiologist, it's better to have everything. And if you can actually afford at the beginning, if you cannot, and if you have like a less number of clients, start with probably functional tests. Depending on the caseload, increase it to like a VNG, and then go with either VHIT or probably caloric, and then eventually expand to, let's say, VEMS. I think having VEMP is important, because it's an electrophysiological testing. It also helps in ABRs.
That's it for the questions, sir. And the recorded version, yes, it is available. So
Yes, we'll be
please conduct
providing. Yeah,
webinar to teach us how to perform and interpret the VEST
definitely.
test,
So you
vestibular
can
test
actually
on, yes.
email us regarding which topic that you need, and we'll try to accommodate as much as possible. I know it will be still limited in
How
terms of experience, but we'll try our best.
how important is to do various vestibular tests when patient is on vestibular suppressants?
So if the patient is on vestibular suppressants, meaning that they are under influence, is as if like they are under
Yes.
drugs. So you cannot actually uh, test, you cannot actually administer a test, because that result is going to be invalid. So the best suggestion is to have the patient ask to stop using vestibular suppressants for at least 24 to 48 hours.
24 hours.
And at least 24 to 48 hours, depending on the dosage. If they're actually using like more than 16 or 24 mg, I would actually ask them to wait for 48 hours, especially if you're on the medication for prolonged period. If it's like 8 mg or so, 24 hours might be fine. But I don't recommend doing any tests when the patient actually had vestibular suppressant very recently, because you're going to find a lot of central issues, definitely, even if it's not central.
So kindly include the topic vestibular migraine in upcoming webinars. So that
Definitely. I think that is one of the important topic. We'll definitely include that in one of the upcoming webinars. Thank you for the suggestion.
kindly review this Q and again. Do all patients with normal central pathway have normal VNG results for central tests? Frequently encounter VNG outputs for saccades, smooth pursuits, and optokinetic tests are not within normal limits. What might be going wrong with the procedure? I think you have already answered for this.
Do all patients with normal central pathway have normal? Uh, no. If patient have a normal central pathway, then we are not supposed to see any abnormalities when we do VNG. So yeah, this could happen. Let me ask you a question actually. So are you observing, let's say, abnormal responses in all patients, such as like a microsaccades or like going square wave jerks randomly? If that is the case, it could be that the sensors might be little, let's say, abnormally function. That could happen either that the reflective glasses actually have some oil on it, so it can actually split the beam, and that could result in these things. But generally, no. If a patient have a normal central function, they're supposed to show normal responses. And if it is
They have
saccades,
mentioned almost all patients for saccades.
yeah, so yes, you have to actually make sure that using proper calibration. So again, one more thing that you should look at is what's the distance between the light bar or TV that you're using as a light source to the patient, and that also need to be actually programmed in the system. So that also plays a critical role. Yes, the patient positioning is also plays a role. Patient positioning as well as the light bar or TV, whatever the stimuli that you're actually giving, also plays a critical role. That could be one of the contributing factor.
Can it be calibration error, attention error by patient, or vestibular suppressants?
So if it is on every patient, I don't think it's an attention error. It could be calibration error or probably the setup itself. Sure. Thank you.
I think we are done with the
Yeah,
Q&A.
it's definitely it's
Uh,
a long session.
yes, sir, but it was very helpful session. Abnormal saccades in migraine.
Yes, we do actually see abnormal saccades in migraine, and migraine can actually it can mimic like anything depending
Yes.
on how it actually works. Yes. Yes, you can actually see vertical, horizontal, and even like a micro saccades. Yeah, it can play like anything.
Yes, yes.
Yes, patients should
Yes,
definitely
they'll be
discontinue
discontinued.
before testing.
How do you encountered, and most of them they have given this pharmacology, mostly they'll give Vertin 16 or Vertin 8 mg, and other, like, you have seen any medications, sir, like any other than Vertin, like
What
any
in
improvement
spin
and
free, Stemetil, yeah, different physicians prescribe different, but again, it depends on what the patient is suffering. If it is a peripheral, definitely not. They have to stop it no matter what. They have to stop it within this first 7 days because the natural compensation kicks in within like another 2 to 3 months. Even without vestibular rehabilitation, they will be like completely normal person. They might feel little off whenever like they move quickly, but apart from that, these people should actually feel completely fine. But if the patient is on these medications for prolonged period, the patient is not going to be becoming better, but he actually is going to become worse, and it can actually end up with triple PD because you're always suppressing the brain on all other sensors. Your brain is like a floating, it's like a half drunk person. So yeah, and we've seen this with several patients. One of the treatment that we gave is just stop the medications and see us in 2 weeks. They call us after 2 weeks and say that, you know what, I'm completely fine, sir, thank you. That's all it is. But depends.
is
But there are people
SPV.
that has central issues, and they may actually need these vestibular suppressants to reduce ongoing signs. But again, only as needed basis.
Is SVV test sensitive for migraine?
So it's a good question actually. Says SVV test can be sensitive. Again, it depends on the severity of the migraine, whether if it is active migraine or not. But if it is no, if it's not active, and probably the patient is completely free of migraine signs, I think the possibilities are that you can also expect normal SVVs.
It might also trigger sometimes, sir.
Yes, yeah, definitely, because it can trigger. Have to be
SVV,
very careful with
yes.
migraine patients.
Yes, sir. Yes. I think we are done with it, sir. So
Yes.
here, before ending this webinar, I would like to thank you and express my heartfelt gratitude for your insightful and informative presentation on balance disorders. Your talk really impacts so many audiologists, and also this will be creating awareness among many audiologists, and also to practice more on balance, vestibular assessments, and management, obviously. So your contribution has been instrumental, and we genuinely appreciate your time and effort. Your dedication to advancing in this field is so much. So here, actually, we have understand a lot, and we can create more of how we can create more awareness and how to keep our own setups in this field of audiology. And it is a very new branch for many of the audiologists who are upcoming, and it is a growing more. So this is so
Absolutely.
evident, sir. It has been our privilege to have you as a speaker, and APSLP Isha always been grateful for this. And also will
Thank
be
you. Thank you.
collaborating for more in future. Thank you
Absolutely.